Okay. Good morning, everybody. So we're not going to lose much time, and I think the first speaker is well known to everybody, the lovely Jennifer Bezaire. Actually, I like your outfit. You know, you have got the same colors as on the emblem of the University of Saskatchewan. So I think it's perfect. The matching green. Yeah, very good. So come on up and give your talk. Thank you.
Good morning. Thank you, everyone. I'm so flattered to see you all sitting in here this morning because I know how hard it is to compete with the beautiful weather here. So I'm glad that you all came back to hear my talk this morning on the Association of Matrix Metalloproteinases with acute kidney injury following cardiopulmonary bypass supported cardiac surgery. This publication is available for free and full text online on PubMed Central if you're interested. I have no disclosures except that I'm going to try my joke again this morning. All right.
Acknowledge me. Acknowledge me. You're going to acknowledge me. You're there, sitting at home. Acknowledge me. The whole world will acknowledge me. Acknowledge me. So MSG, acknowledge me. Acknowledge me. Acknowledge me. Acknowledge me.
This is me when surgeons try to ignore me.
Acknowledge me. Acknowledge me. Acknowledge me.
I was playing it in the OR one day, and the scrub said to the surgeon, "I think she wants you to acknowledge her." He was like, "What?" All right, so this is what I want to cover this morning. Background, hypothesis, methods, results. We'll have a discussion, talk about the limitations and conclusion, and then did we decide on a panel discussion after? Oh, no. Then we'll have some time for question and answer period. So we know, we've been talking a lot about AKI this conference. We know that it's an adverse outcome in our patients undergoing bypass and that it increases morbidity and mortality. We have no definitive prevention or treatment as of right now. And again, clinicians are still using serum creatinine and glomerular filtration rate to evaluate renal function. And I'm going to hate on it again a little bit more this morning and remind you that this ignores the fact that tubular injury precedes a significant rise in serum creatinine, which delays early treatment because creatinine can rise so slowly, 24 to 72 hours following renal injury before you'll see an appreciable increase for a patient to meet criteria for AKI. In contrast, serum and urine matrix metalloproteinases 2 and 9 can identify AKI earlier than serum creatinine. And I'm going to show you how. And these can serve as potential predictive and diagnostic biomarkers of AKI. So our hypothesis was that the increased activity of serum and urine levels of MMP2 and 9 were associated with and may provide earlier detection of cardiac surgery-associated AKI. It was a prospective proof of concept pilot study, and we enrolled 150 cardiopulmonary bypass supported adult cardiac surgery patients. 21 of them developed AKI according to KDIGO's 2012 criteria. So this research took place between 2018 and 2019 before the 2020 criteria came out. And then we matched another additional 21 patients who did not develop AKI from the remaining 129 patients, and we matched them based on their demographic and clinical data, age, gender, BMI, Euroscore, their pre-bypass renal function, and type of surgery. So that gave us a final sample of 42 patients divided in two groups, 21 in the AKI and 21 in the non-AKI. We then measured urine and serum specimens for MMP2 and 9 activity at 3 time points, baseline pre-bypass, 10 minutes post-bypass, and 4 hours post-bypass. We measured creatinine also at baseline pre-bypass, 4 hours post-bypass, 8 hours in the ICU, 18 hours in the ICU, and daily for the patient's remaining length of stay, which is 7 days. We calculated the estimated glomerular filtration rate for the patients using KDIGO's 2012 chronic kidney disease EPI equation, and the MMP activity was assessed using gel zymography in the lab. This is KDIGO's 2012 AKI classification criteria that we used. Highlighted in red is what we stuck with serum creatinine increase greater than or equal to 26.5 micromoles per liter within 48 hours, or serum creatinine increase 1.5 to 1.9 fold above their baseline in 7 days. And then stage 2 is a serum creatinine increase 2 to 2.9 fold above baseline. I just want to note that, again, we didn't use the urine output criteria for this study because it's not well validated, and we wanted to stick with the objective, accurate measurements of creatinine. So the results. So this is our demographic and clinical data. There was no significant differences between the baseline demographics and clinical characteristics in the AKI and non-AKI groups. And that's expected because we used a matched design, so we wanted to make sure that they were similar as possible in both groups. The operative and post-operative data is here. You might notice that transfusion of red cells, platelets, and FFP was significantly higher in the AKI group, as well as length of stay in the ICU and ICU fluid balance. There was a difference of about 1 liter between the two here. The types of procedures, mostly cabbages, valves, or combined procedures. We did have one ASD closure. This table shows you serum creatinine and estimated glomerular filtration rate. Within the AKI group, there was no significant differences between serum creatinine pre-bypass and 10 minutes post-bypass. The levels rose significantly at the 4, 8, and 18-hour intervals in the AKI group. And in the non-AKI group, there were no significant differences between pre-bypass and all other time points. Between groups, there was no significant differences pre-bypass or 10 minutes post. However, there were significant differences at the 4, 8, and 18-hour intervals. Glomerular filtration rate was significantly lower in the AKI group at all post-bypass time points. And again, this data for me is expected because of the study design, the matched design, and the criteria that we used to sort the patients into each group. This table shows you the time it took each AKI patient to meet the 2012 criteria, and it was between 8 and 72 hours with a mean of about 30.67 hours. And this graph is showing us serum MMP2 activity at all 3 time points. So you have the non-AKI patients in black and the AKI patients in white. And we've got them pre-bypass, 10 minutes, and 4 hours post. And there was no significant differences between the pre and post bypass time points within the non-AKI group. So you can see all of these looks about the same. And within the AKI group, serum MMP activity rose significantly at the 10-minute and the 4-hour post-bypass time points as compared to the pre-bypass time point. And then between the two groups, serum MMP2 was also significantly higher in the AKI patients at 10 minutes and 4 hours post-bypass. So let's look at MMP9. We have a similar pattern. Within the non-AKI group, there was no differences between the pre and post bypass time points, but within the AKI group, serum MMP9 activity then rose significantly at the 10-minute and 4-hour post-bypass time points compared to the pre-bypass time point. Between the two groups, serum MMP9 was also significantly higher in the AKI patients at the 10 minutes and 4 hours post-bypass time points. Now I'm going to show you the urine MMP activity. So between the groups, we can see that urine MMP2 is significantly higher, again, in the AKI group as compared to the non-AKI group. And within the AKI group, urine MMP2 activity was significantly higher at the 10 minutes and 4 hours post-time point as opposed to the pre-time point. Interestingly, though, the non-AKI group also demonstrated significantly higher urine MMP2 activity at all time points. So it tells us there's something going on in these patients' pathophysiology even before we put them on bypass. So let's look at urine MMP9. Within the AKI group, urine MMP9 activity was significantly higher at the 10-minute and 4 hours time points when compared to the baseline. And in the non-AKI group, it was I don't think that's correct. I'm not going to say that. Between groups, the urine MMP9 was, I think it's a typo in my notes, copy-paste error, sorry. Urine MMP9 was significantly higher in the AKI group compared to the non-AKI group at all time points here. And now I'm going to show you how we looked at their predictive capabilities. So this is a receiver operator characteristic curve of serum MMP2 10 minutes post-bypass. And it tells us the ability of serum MMP2 at this time point to predict AKI. This was a good model with area under the curve of 0.88 and a 95% confidence interval of 0.779 to 0.987. The cutoff value for serum MMP2 at this 10 minutes post-bypass time point was 26.3 arbitrary units with a sensitivity of 0.95 and specificity of 0.77. And the J statistic was 0.72. So I'll show you the same thing for urine MMP2 at 10 minutes post, which was also an excellent model. The area under the curve here was 0.915 with a 95% confidence interval of 0.83 to 0.99. And the cutoff value was 12 arbitrary units with a sensitivity of 0.95 and specificity of 0.73 and a Uden index of 0.72. Serum MMP9's 10-minute post-bypass ability to predict AKI was also a good model. The area under the curve was 0.756 with a 95% confidence interval of 0.6 to 0.9. Since this was slightly above the 0.75 cutoff for area under the curve for a good discriminatory value, we proceeded with the detailed sensitivity and specificity analysis. And the cutoff value for serum MMP9 at 10 minutes post-bypass was 37 arbitrary units. The J statistic was low, though, at 0.34. So an acceptable Uden index is 50%, so keep that in mind. Let's look at urine MMP9. And so the area under the curve of this one was also excellent, almost perfect at 0.955 with a 95% confidence interval of 0.898 to 0.99. The cutoff value was 102 arbitrary units with a sensitivity of 0.95 and specificity of 0.86. And this one had the very best Uden index of 0.81. So I'll show you the curves superimposed. So we have In blue is serum MMP2 area under the curve, which is 0.88. And in red, we have serum MMP9 under the curve, which was a fair model at 0.756, but not as good as the blue one. And here we have the urine MMP2 and 9 superimposed on each other. So blue, again, is urine MMP2, and red is MMP9. And red was the best model, but these were both excellent. They're both very, very close to one in the top left corner here. So moving on to the discussion. Serum and urine MMP2 and 9 activity was significantly increased at the 10-minute post-bypass time point in patients who developed AKI compared to those who did not develop AKI. Serum and urine MMP2 and 9 rose earlier than serum creatinine. And this tells us that they might be useful in the early detection of cardiac surgery-associated AKI. And then I wanted to mention that although it wasn't statistically significant, our data also showed a trend towards higher baseline MMP2 activity in patients who developed cardiac surgery-associated AKI, suggesting other mechanisms might be at play even before we put the patient on bypass or before we cross-clamp or have any cardiac or renal ischemia reperfusion. The serum creatinine 4 hours post-bypass was significantly higher in the AKI versus the non-AKI groups. And we were wondering if that might be due to hemodilution, and if hemodilution also affects the delay in serum creatinine in patients. A lot of patients at this 4-hour post time point did not meet criteria, even though they went on to develop AKI, which delayed their diagnosis and treatment. Also, just want to highlight again that there was significantly higher blood product transfusion in the AKI versus the non-AKI group. They had lower hematocrits, higher fluid balance, and longer ICU length of stay. And we all know what that means. So I want to take a moment to discuss ischemia reperfusion and MMP activity. So despite all of our modern cardioplegia techniques, thank you, ischemia reperfusion injury still occurs in our patients. And ischemia reperfusion activates MMP2. And the contractile proteins in animal and human cardiac sarcomeres are degraded by the proteolytic enzyme MMP2 during ischemia reperfusion. And so prior to this study, the relationship between MMP2 and cardiac surgery-associated AKI had not been investigated. And we found that 10 minutes post-bypass gives sufficient time for the biomarkers to reach the proximal tubule and be present in the urine for measurement. And our data suggests that the increased MMP2 and 9 activity from cardiac ischemia reperfusion may be associated with the increased MMP2 and 9 activity in the systemic circulation of patients who go on to develop AKI. But then there's also renal ischemia reperfusion and MMP activity to think about. So MMPs degrade the extracellular matrix, and they're involved in ischemic organ injuries. And our center had done a lot of research on kidney preservation for transplant, demonstrating this. We also had a rodent model that showed MMP2 and MMP9 were increased in the renal tubules in the interstitium following 1 to 3 days of reperfusion after 52 minutes of ischemic time. And keep in mind that there are many, many pathways of pathophysiology in cardiac surgery-associated AKI. So it's all suggestive. It's not necessarily causation. It's associative. And we also know that from these studies in renal preservation for transplant that Semisynthetic tetracyclines directly antagonize the effects of MMP2 and 9 in the renal microvasculature following ischemia reperfusion. So there's two types of antibiotics, doxycycline and minocycline, that may help us prevent renal injury in our patients that we could continue to investigate. They are added into the renal perfusate when we're doing transplant procurement, and it helps decrease the MMP activity. Moving on, the earlier diagnosis of cardiac surgery-associated AKI can impact patient care by decreasing the severity and progression of AKI, can improve the patient's outcomes, it can improve our risk stratification, and improve discrimination between renal dysfunction and injury. Limitations of this study include small sample size, single center, and the inability to distinguish where the MMPs are originating from, whether it's the heart or the kidneys. We could not get ethics approval to cannulate the renal artery because of increased risks. However, if you were able to take a sample from the coronary sinus and the renal artery, probably before and after cross-clamp, then we might be able to confirm the origin of MMPs in the biofluid, which is what we did in the rodent model previous to this study. Maybe some of your centers aren't as strict as ours in Canada. The cohort with normal baseline renal function. Okay, so all of the patients in this study had normal baseline renal function, and so we would need to repeat the analysis in patients that are high risk with pre-existing renal dysfunction, as many of our patients have, and patients that are also exposed to nephrotoxic drugs. And so we just have to do the validation in a larger multi-center prospective trial, just like everything. In conclusion, AKI is associated with increased mortality, complications, and length of stay. The literature suggests two sources of MMP2 and 9 activity associated with ischemia reperfusion following bypass, the heart and the kidneys. This study demonstrated an association between increased MMP activity and cardiac surgery-associated AKI. They rise earlier than serum creatinine in cardiac surgery-associated AKI patients, and they may be pharmacological targets for us for renal protection during cardiac surgery. And my time's almost up, so that's it.
Thank you very much for this wonderful talk. Are there any questions from the audience or online? Yes, George.
Thank you. That was a great presentation and great science. Really appreciate that. I think we all agree that we need better early indicators of AKI than latent indicators like serum creatinine. In your data, there was lower glomerular filtration rates in the AKI group compared to the non-AKI group, and you had higher MMP markers in that group as well. Have you considered extending your study to get a larger sample size, and do you think it would become significant?
That's what's happening right now. Yeah,
okay.
It is possible. We also saw a lot of very close to significant numbers in the data for a lot of the pre-bypass measurements as well. And so we were thinking initially, both for this study and the one that I presented Wednesday morning, that you'd be able to identify patients at risk prior to even going on bypass and maybe have an opportunity to optimize them ahead of time. But then as we've been collecting more data, it's been moving away rather than closer towards, so I'm not sure. Also, as we come out with the results, practice is changing in the center. So I know that affects it as well, so we might have to recruit hundreds of patients before we're able to see that association.
And just one more quick comment. When we take our data and we run it through machine learning algorithms. One of the surprises that came up to us as far as bypass factors that influence AKI in our patients was cross-clamp time was more important than the total bypass time. And so
I can understand that based on the pathophysiology of ischemia reperfusion injury and the MMPs that are released.
yeah, and the unfortunate consequence is those patients also have longer bypass time.
Yeah.
Excellent presentation.
Thank you.
As you can see, the pro and con guys are both asking you questions. So, hemoglobin management is a big interest of mine. And was that red cell transfusion packed cells or washed red cells?
Packed cells.
Do you think having washed red cells would have impacted that AKI? And
Absolutely.
Do you think optimizing prime or minimizing prime so that you impact colloid osmotic pressure will also impact AKI?
I think so. Anything that minimizes hemodilution, I think would help prevent AKI or minimize the severity of it, of what the patients do go on to develop. There's definitely an association between blood cell transfusion, but also platelet transfusion and FFP transfusion independently with the development of cardiac surgery-associated AKI. So there's a combined effect as well as an individual effect. So those other blood products are not without impact or sequelae. And I asked this on Wednesday, but I'll ask it again because maybe there's more people here this morning. Is anybody using single donor?
There's one last question from the chat.
Oh, sorry, go ahead.
We have two quick questions from the chat. Robert wanted to know, do you find any benefit / added trouble with the addition of Lasix or mannitol to increase of AKI and IV drug abuse?
No, we don't. In this center, in this cohort, we are not giving Lasix during bypass or in the OR, but we do prime with mannitol, and we do give another dose, the standard 0.5 gram per kilo dose, just before and when the cross clamp comes off. In this center, they're running it as a drip, so it's not like a push bolus, so the patient is getting it for a period of time in a steady state before the clamp comes off and as the clamp comes off and just after the clamp is coming off.
And then one last one. It's kind of a consensus of everyone kind of asking how practical is running the labs of the MMP, and then what's the cost? Are they run in hospital or being sent out?
I need to talk to some industry people about this because they are, so for this study, not practical at all because I did it by gel zymography and ELISA, so the samples were all frozen and then had to go to the lab and set it all up once I had enough to make a full 90 plate. And, but they've found MMP2 in tiers of humans that have problems with dry eye, and they're developing a point of care test for it. So I'm like, well, AKI seems to me like a bigger problem than dry eyes. I don't want to, I mean, I've had laser eye surgery and it felt like sand in my eyes and it was very painful. I do agree that it is worth looking into, but I feel like if we can make a point of care test for optometrists, why can't we make a point of care test for us in the cardiac OR?